Hi, I'm Sachin Gupta, and in this short video, I'm going to discuss my paper, which was co-authored with the three co-authors shown here and published in the Journal of Marketing Research in December 2018. Later in this video, you will also hear from Tulsi, who is one of the co-authors shown here. So the context for our paper is healthcare delivery in developing countries and the role of nonprofits. In most developing countries, there is a large burden of disease. Government-provided healthcare services are not adequate, and private for-profit services are not really affordable by many poor patients. So in this context, there is a significant role that non-profit firms that are motivated by altruism can play in providing services to poor patients. What we are studying here is a cross-subsidization business model for nonprofits. So what happens in this business model is that the nonprofit provides services to poor patients for free or at subsidized prices, offers the same or similar services to other patients at higher prices, and thereby cross-subsidizes between the groups of patients. An economist would call this second-degree price discrimination through versioning. Aravind Eye Care System is a success story that follows this business model. There are several other examples as well, but we will closely follow the story of Aravind Eye Care.
Worldwide, 285 million people are blind or visually impaired. 80% of that blindness is avoidable. A simple operation can restore sight. But for many, the cost of treatment is simply too high. Here in South India, in a city called Madurai, Aravind has been working to turn those economics around. When people walk into an Aravind Eye Hospital, they have a choice, whether to pay for treatment or to receive it for free.
So what happens at Aravind is that they treat three groups of patients. On the left, you will see walk-in patients, which are of two kinds. There are paying patients who, for a service like cataract surgery, will pay market prices that may range from $100 to $700 for the cost of the surgery. Second group of patients is subsidized patients who pay a very low price of about $13 per surgery. And then the third group of patients are camp patients who are treated entirely for free. And Aravind goes out to the camp patients and undertakes significant amount of marketing to attract these patients who don't pay anything for the surgery to its outreach camps, from where qualified patients are transported to the base hospital and treated. But Aravind does no marketing to the walk-in patients, neither the paying patients nor the subsidized patients. And what we are studying in this paper is the effect of the marketing to the free patients that then spills over to the paying patients, which are paying and the subsidized patients.
When Aravind first opened its doors and offered free service, it discovered another barrier to access. Many patients lived in rural settings, far away from a hospital. They could not afford the cost of the journey. Since these patients could not come to Aravind, Aravind went to them. A series of eye camps were launched in rural areas.
The camp is basically an outreach program. So we come to the places which are not easily accessible. We do a screening for them, and the patients that require surgery, we'll take them back to the base hospital, do a surgery free of cost, and bring them back here.
This woman has a cataract in her left eye.
கீழே பாருங்கம்மா, நம்ம புற ரொம்ப இருக்கு, சரியா? அதனால பின்னாடி நரம்பு எப்படி இருக்குன்னு இப்போ சொல்ல முடியாது. கண்ணு பண்ண மாதிரியெல்லாம் இந்த கண்ணு இப்போ அந்த கண்ணு இப்போ கொஞ்சம் தான் இருந்தது இந்த கண்ணு இப்போ ஜாஸ்தி இருக்கு.
She is one of 200 people from this village whom Aravind will bus back to the main hospital for surgery, where they will receive food, lodging, treatment, return transport, and follow-up care completely free of charge.
What we use for our paper, for the analysis, are data from one of Arvind's hospitals, which is the Pondicherry Hospital. We have 1.4 million patients who were treated between 2003 and 2014 in the Pondicherry Hospital. We have a lot of details about the patients, the patient type, the patient location, which we have geocoded, the hospital visit date, and so on. We also know the dates and locations, which we have geocoded, of all 2,500 outreach camps that occurred. And what we are doing is, through an econometric model, we are looking at the covariation between the camp dates and locations and the walk-in patients' locations and dates to infer the effect of the camps on the walk-in patients. And the way this occurs in the context of the model, and I have a graphical depiction of this, is that this is the location of the Pondicherry Hospital. And to give you a sense of scale, this is about a 26-mile radius. When a camp occurs, the patients who are located in the vicinity of the camp, these are walk-in patients, how are they affected by the occurrence of the camp? This is what the model is really capturing. Our key results are essentially that each camp generated incremental walk-in patient demand of about 3.3 subsidized patients and about 9.7 paying patients. This incremental demand resulted in incremental revenues of about $2,273 during the 1 year after a camp is held. And when you compare this with the cost of a camp, which is about $710, the incremental revenue comfortably covers the cost of the camp. In other words, a camp pays for itself.
Aravind's aspiration of eliminating needless blindness led to a design of an inclusive service delivery model. This includes proactively reaching out to rural and poor communities through free outreach eye camps. Having adequate paying clientele was critical for financing the free care to the poor. Over the years, as the outreach grew, so did the paying patients. This study explaining this dynamics is incredibly important to LICO, the external scaling arm of Aravind. LICO works with over 350 eye hospitals and has trained over 2,700 managerial professionals in eye care from India and 70 other developing countries. LICO promotes best practices to enhance eye care in other programs in a financially sustainable manner. In this endeavor, we are able to employ the learnings of evidence-based studies such as this one.